So it gives me great pleasure to introduce our next speaker, Dr. Mariam Beauchamp, who's a neuropsychologist and Canada Research Chair in Pediatric TBI, professor, Department of Psychology at Université de Montréal, researcher and director of the Brain and Development Access Saint-Justine Hospital Research Center. And she's going to talk about bridging the early childhood gap using unique developmental approaches. She's full professor in the Department of Psychology at University of Montreal and at Saint-Justine Hospital, where she leads the ABC's Developmental Neuropsych Laboratory. She holds the Canada Research Chair in Pediatric Traumatic Brain Injury. And in 2017, she was recognized as Quebec's most promising early career researcher and has been awarded early career awards from the International Neuropsychological Society and International Brain Injury Association. And she was inducted in the College of New Scholars of the Royal Society of Canada. Mariam, welcome.
Thank you, and thank you for the invitation to be here and talk about concussions, but through a slightly different lens. So we've heard this morning about all sorts of types of concussions. We've talked a lot about sports concussions. We've talked a little bit about blast injuries and about aging, and I'm going to take you in the other direction to the very beginning of life. So we all agree on what a concussion is. But really, I'm going to talk about different types of injuries. So this is a typical example of the sorts of concussions that we study. So this is the story of Zachary, who fell down the stairs while they were at the cottage. All the adults were busy and the kids were playing rambunctiously, and he fell down the stairs. He lost consciousness for a few seconds, and he had some bleeding from some lacerations, but they also diagnosed him with a concussion. And this little boy showed signs and symptoms that you'll all recognize and know, headaches, for example, being irritable. But there were also things that were sort of unique to his situation. So, he didn't want to play the usual games he wanted to play. His parents described his behavior as being more difficult. He wanted to be in his mom's arms more, which was starting to be less usual at the age of 5 years. And his parents talked about feeling very anxious about their child's injury. So that's quite typical. I'm going to show you another brief video where you'll hear there's some images that are just sort of stock images, but you're going to hear an actual patient. You're actually going to hear a little girl who's 2 years old. She's a little bit difficult to understand, but you'll get the gist of what she says. And her mom described their injury. So I'll let you listen to that.
Do you remember, Claire, how you hurt your head?
Yeah.
Yeah? Can you tell me? How'd you hurt your head?
I fell downstairs.
Yeah? Did it hurt?
Yeah.
Oh. Okay.
Mommy was upstairs.
Yeah?
And I've been at the top.
Oh, and you were at the top of the stairs?
Yeah.
Oh.
And some doctors didn't tell me and make sure I'm okay.
Yeah? And you're okay now?
And some doctors.
Doctors?
Yeah.
Yeah? They checked you?
Yeah.
We're talking about the firemen and the paramedics that came to our house. They came to our house to make sure that she was okay.
So now I'm just gonna ask you if you could tell me a little bit more also about the story of how she got injured.
We were going up the stairs from our basement because we park in a garage that's in our basement. Okay. And I have a 1-year-old daughter who was crawling up the stairs, and she was going up the stairs kind of right behind it, kind of vis-a-vis myself, a little, maybe a step behind.
Okay.
And I guess she slipped and rolled in the stairs and then landed on her kind of upper body, the shoulder and head.
Okay.
So I went downstairs to get her. I was holding her in my arms, and she, I guess she convulsed in my arms.
Okay.
So for a few seconds, she wasn't conscious. She was posturing with her left arm, and her
got
eyes were turned to the left.
I got
And then she lost consciousness for a couple of seconds
I
as
got
well. And then she came to. And when she came to, she was alert and she was aware of what had happened.
Okay.
And she was able to say, I fell down the stairs and have a boo-boo.
Okay.
And so she was alert when she came to in my arms.
And can you tell me like how she reacted when she got hurt? I guess after when she came to, I guess.
She was crying. That's how I heard that she was falling, because I guess she cried when she landed.
Okay.
Then she was in my arms after that. I picked her up. She was in my arms. She cried for not more than a minute in my arms.
Okay.
And then she started sucking her thumb, which is, she's been doing that since she was a baby. So she sucks her thumb for comfort.
I'm going to stop it there to move on, but you get the gist of the story. And just to keep in mind, because we'll come back to them, some of those signs the mother was just saying, she cried and she was sucking her thumb, for example, and she was in her arms. And the reason, I really, we're focusing on this age group is that it's an age group that we don't really talk about. In fact, a lot of people will say to me, well, concussion doesn't really exist in young children, but biologically, there's no reason to think that concussions don't exist. They just look different, and they need to be looked at through a different lens so that we can understand how they manifest and how we're going to treat them and how we're going to manage them. In terms of overall presentations for head injury, all head injury sort of broadly characterized is actually a 0 to 4 year old group that has the highest presentation. And some of those presentations will obviously translate into official diagnosis of concussion. So what I'm going to come back to this at the end too, but what I want you to keep in mind are these unique characteristics of early childhood that might make a concussion different. So these may seem like fairly obvious things to you, but we often forget about them and just apply what we know to all ages. So, little kids have different structural characteristics, different body sizes, different head to body ratio, different skull density at young ages. They're in a period of very rapid brain development. Their cognitive skills are not fully consolidated. Many of the kids that we study are under 2, so their language is limited if at all present, and they might have limited abstraction skills. In terms of their environment, they're not necessarily in school. Some of them might be in school if they're 4 or 5, but others might be in daycare or just at home. And also they're more dependent on their parents, right? They're more often with their parents, and maybe they listen to their parents more than teenagers do. So we'll come back to these characteristics. Now, you all know these typical post-concussive symptoms, and the first set of data I'm going to present to you is going to be on post-concussive symptoms in young kids. So they're a commonly reported outcome. We all rely on them quite heavily for diagnosis and for tracking what a patient, how they're feeling, if they're feeling any better. And in some kids, they might persist for some time, in some adults as well, as we've just seen. So post-concussive symptoms in young kids, many post-concussive symptoms are typical of everyday behaviors, right? We need to think about pre-verbal children. How are they going to tell us that they have a headache, for example? Many post-concussive symptoms are also quite abstract, even to an older child or even an adolescent or maybe even an adult. Like, what does it mean to feel dizzy or feel confused? We've asked ourselves the question, do all of the same symptoms apply, or are there things that are unique in young children, or maybe some things don't apply to young children? So there might be some unique behavioral manifestations. So this is what we're going to look at. And to do that, we developed this post-concussive symptom inventory called Reactions. And the goal of it is not to reinvent the wheel, is to base things on what we know about post-concussive symptoms, but really to be able to present them in a way that a caregiver or a clinician can be able to observe their child and say, yes, I think this is what I'm seeing. We started the reactions measure with 17 different symptoms across 3 domains, and there were in total 106 different manifestations, different examples that parents could endorse to say whether they'd seen that in their child. And we used that first set of data to reduce that down to 16 symptoms across 48 examples, so fine-tuning the measure a little bit. So this is just an example. So in the headache category, a parent might say, yeah, my child seems to have a headache. Just like on any PCS questionnaire or inventory that you know, a parent might say, yeah, my child says they have a headache, right? But they might also, if they can't say that, they might rub their head or they might hold their head, for example, and that might be a sign that their head is, that they're feeling pain in their head. There's a whole big behavioral domain that's much more expanded than in what the questionnaires that you might be familiar with. So being irritable, crying more, having tantrums, for example, which would be manifestations that are more typical of younger children. then, so I haven't gone through all through them, but I'm happy to provide other examples if there are questions on that later. And the data that I'm going to present to you comes from this study called the Koala study, where we looked at the outcomes of kids who were injured with concussion between 6 months of age and 6 years of age. And we followed them across all these time points. We're currently trying to follow some of them 4 years later. And we did a whole lot of measures. I'm only going to present on post-concussive symptoms today, but it's a big study. We did a lot of direct cognitive and social assessments. We collected saliva. Some of them went in the scanner. I can talk about that a little bit later. We have hair cortisol samples. We have a lot of fun things to look at. Okay, so the actual data I'm going to present to you, the Koala study happened in 4 hospitals, so the 2 Montreal pediatric hospitals, St. Justine where I am, and Montreal Children's Hospital, as well as Alberta Children's Hospital and Nationwide Children's in Ohio. And the data is from 174 kids with MTBI or concussion. We did an analysis where we excluded those who had positive imaging. There are 6 kids in that sample that have positive imaging, but it didn't make a difference in our results. There are 60 kids with orthopedic injuries, so a comparison group with orthopedic injuries. And we have a community control group of 64 children. So I've always been adamant that we have both of these control groups because there are a lot of questions about whether this is not just typical everyday behavior and not associated with injury. So I'll show you the data for both those groups. We have a very imperfect pre-injury rating of post-concussive symptoms. So as soon as we recruit the families, we ask them to fill out the reactions inventory as to how their child was before. As you know, this is often our only way of having some baseline information because we can't predict when these injuries are going to happen. And I'll present data from the first 3 time points. So within 48 hours of the injury, this is in the emergency department, and then post-acutely 7 to 14 days after, and then around 30 days, so around 1 month. So this is what it looks like. On your top left, sorry, you have the total symptoms on the reactions measure and then divided by subdomains, so cognitive, physical, and behavioral symptoms. So it's pretty easy to see on there the differences. The blue and the red are your 2 control or comparison groups, I should call them. The community controls in blue and the OI is in red. And the concussions are in green, where you can see they have very significantly elevated post-concussive symptoms compared to the 2 groups, particularly at the emergency and at 10 days and at 1 month. But even at 3 months, they haven't come all the way down back to being comparable to the 2 comparison groups, okay? I'll give you a little bit more fine-grained information. This is just the number, basically, of post-concussive symptoms that the groups are showing. So the concussion group across time showed between 5 and 8 symptoms, whereas the other 2 groups showed between 3 and 5 symptoms. So just looking at the actual number of symptoms. So if the parents endorsed any one of those manifestations, we considered that that symptom was present in that child. And this is even more fine-grained, and I'll just point out some examples. So here we've broken it down into the actual 17, in this case, different symptoms. So they're written there under the domains. And I'll just point out some interesting observations. So lots of elevation in things that are sort of related to physical symptoms, headache and nausea, things that you would expect in anybody with a concussion, things like fatigue and drowsiness also. And then lots of things in the behavioral area as well, like very excessive irritability, for example. One thing that we did not see in this is that in the inventory, there's a sub question on regression. Does the child show any behavioral regression, like they were not sucking their thumb anymore and now they're sucking their thumb, or they were toilet trained and then they're having accidents or things like that. So in this cohort broken down this way, we did not see any difference between the groups, but we have a separate set of data where we separated out the 0 to 2-year-olds and the 3 to 8-year-olds. This was in another study. And it was really interesting because the 0 to 2-year-olds did not show any regressive behavior either. In some ways, they don't have all that far back to regress to, but the older group showed those regressive behaviors in that group. Okay, so what we see in this data, many typical symptoms are observed: inattention, slowing down, headache, nausea, fatigue, poor sleep, vision problems. They're all typically well-documented symptoms in school-age children and in adults. What we find that using this observational tool, we were able to detect them in a way that was more useful, obviously, to the caregivers and more insightful for us. So the next slide I've called something old, something new. So something old, something we'd expected, but also what we found was really more unique manifestations of behavioral changes, I guess we could call them. Really, irritability was a very prominent symptom. And when you think about it, it could mean any of those other symptoms. So the irritability could be because they have a headache, or because they are not sleeping well, or because they're feeling nauseous. So they're sort of general symptoms indicating the child feels unwell. And the other thing to point out was really these what we call comfort-seeking behaviors. So wanting to be held more, sucking their thumb, wanting their blanket or their stuffed animal, and really thinking about the role of their limited ability to convey what they're feeling to their parents is sort of coming out in these behavioral comfort-seeking and mood manifestations. So it's really all about behavior in this age group, and I'll come back to that. In fact, I'm going to move on to a different set of data that's going to be about actual behavior changes after these types of injuries. This is in a different so this is in a different study cohort. This is in the Lion study. In this study, the kids were between 18 months and 60 months, so 5 years when they were injured. So very similar inclusion criteria, except in this study, we saw the kids in the emergency department, but then we didn't see them again for 6 months. So I'm going to present to you data from 6 months after their injury. Again, I think neuropsychologists like to sort of just throw everything at their participants and patients. We collect a lot of data in all of these areas, and I'm going to talk to you more about the family and behavior area. We used to track behavior, the child behavior checklist, not a very innovative measure, but what we have and readily available, it's just a questionnaire looking at internalizing and externalizing behaviors over 100 items. And we let the families decide who would fill it out. In 90% of the cases, it was mothers. So the first bit of data I'm going to present to you is only from those from the 90% of the mothers that completed it. Okay, so this is what it looks like. This is 6 months post-injury, and you have in paler green the concussion group, and then the OIs and the community controls. Again, those two control groups. And basically, what you can see is that on both the internalizing and externalizing scales, the kids with concussion or MTBI had significantly elevated behavioral problems on both those scales compared to both the other groups. Now, a lot of people say, okay, well, these are just raw scores, as you can see on the y-axis. So, just to mention, this is taking into account there were no pre-injury differences on these retrospective pre-injury scales, and compared to both groups. So are they clinically significant, these behaviors? Because those were raw scores that I showed you. So this is looking at what percentage of kids had scores in the clinically significant range on the CBCL. And so what you can see, the paler ones are the typical range, and the darker color are the clinically elevated. So you can see that the MTBI group had 38% of kids in the clinically significant range compared to 26% and 19% in the control groups. And actually on their pre-injury questionnaires, the concussion group, sorry, I keep switching, but for the purpose of this concussion and MTBI, we'll equate them. But the concussion group had 19% at pre-injury, and that rose to 38%, okay? All right, so how can we predict these problems, or what's contributing to these behavior problems. So we looked at a predictive model in which we looked at some injury-related factors, some parent factors, and some child factors. And what we found was, unsurprisingly, on the child side, if the parents had rated them as having some behavioral problems pre-injury, then they were more likely to have behavioral problems post-injury. But as you saw in the previous slide, that didn't account fully for the changes post-injury. Interestingly, in terms of parent factors, parent stress was a significant independent factor of the child behavior problems. So the parent reporting that they were feeling also stressed. So there may be both an individual contribution on the part of the child, but also something going on with the parent. And I'm going to come back to that in a kind of more integrative model in a few minutes. This is what the data looks like up to 30 months post-injury. And this was quite surprising to me. And we've looked at the data in different ways. This is trajectory modeling of the data. And basically the concussion group has not come down the lines are just going on parallel over time. And we were quite surprised and concerned about this, and in some ways quite skeptical, because to me, it's fairly surprising that these kids would continue to have behavioral manifestations. So we've been looking into why that might be the case, especially if it's not just pre-injury functioning that's explaining the data. Okay. I'm going to say a word before I move into more social interactions about, I mentioned to you the data was on the 90% of mothers who answered. However, so in trying to understand the data, we thought, well, are the parents wrong? Are they themselves just so stressed and anxious that they're saying that their child has these behavior problems? So we compared the data from the mothers and the fathers, the 10% of fathers who had it. And actually, we only find behavior problems when the mothers fill out the questionnaire. Now, I'm not saying who's right and who's wrong. What I want to point out here is that it's really important to ask both parents what their perception is. Are the mothers so stressed that they're reporting too much, or are the fathers disconnected and not noticing things? I'm not going to get into that. But the presentation today, if you remember my title, is also about what developmentally appropriate ways should we be using to understand this data. And so what we're doing, I think my next slide is on that, but what we're doing at the moment is we have all of our assessments filmed, and we're going back to the assessments, to the video assessments, and we're using 2 observational coding systems to see. Of course, we're not at home. We're not at the child's home, but these are validated observational behavior coding scales that have been designed to be used in a more structured environment, like a one-on-one testing environment. And we're going back, and my student Lara Kim is coding all of these videos to see whether she finds that there are externalizing and internalizing behaviors on all of these videos. So I don't have the data for that, but this is one of the other ways we're just trying to make sense of it, and also have a sense of whether we can replicate what the parents are saying, or whether it might be different what we see. Okay, I'm going to say a few words. This is also about behavior, but about parent and child interactions. If the child is showing difficult behavior in the parent's opinion, then that could be impacting, of course, on their relationship or on their day-to-day interactions. And we know from many, many other studies, and I've listed just a few of them on the bottom there, that TBI impacts family functioning, but also family functioning impacts traumatic brain injury and its recovery. So there are many things we can look at here, but I'm going to focus on parent-child interactions. In this same sample, what we did was we used a scale called the Mutual Responsive Orientation. This is also an observational coding scale that's from developmental psychology. It's very well validated. It's used extensively in studies of developmental psychology in both normative populations and clinical populations. And what it really emphasizes is the ratings are on the dyadic nature of the parent and child exchanges. That means we're not just looking at the child's behavior, or we're not just assessing, for example, maternal sensitivity, okay? We're looking at the combination of the two. And what we did was, within our neuropsych assessment, the kids did 2, and their parents did two segments of about 10 minutes each, in which in one of them they just had a sort of free play toy session, and in one of them they shared a snack, and we also used that as our little break. And we film all of those sessions, and they're scored afterwards according to this scale. And the scale looks at whether the communication between the two is harmonious, whether there's signs of mutual cooperation, and whether overall the atmosphere is positive emotionally. Okay, so I'm going to show you just a little video where you see during the snack time a mom with her little baby. Oh, sorry. I think I went too quickly there. Don't know if that can be started from somewhere. There we go. Okay.
Same. Same. I knew you were gonna do that. Juice, yeah. Juice. You want some juice? Juice, so it's not sticky. Here, you want juice? Here, mommy hold. Yeah, good boy. See what I mean? Yeah. Agua? Agua or juice? I can't get the agua right now. You want this? Fruits? Are we gonna clean up the box? You want the house?
Yeah, I won't run it all the way through, but they continue to play and then they pick up together in that. And of course, I showed you a nice interaction. You see, he spills the juice and she picks it up, but she's not angry, and then she helps him with the applesauce and things like that. So we have hundreds and hundreds of these videos that we've coded. And this is what the data looks like for that. It will look much like the pattern in the behavior data. So in concussion, this time you have the concussion group in red, the OIs in blue, and the typically development or the community group in green. And again, there's significant differences between the concussion group and the two control groups, with the orthopedic group falling somewhere in the middle, as we might expect them to. And this is on all three scales of the mutual responsive orientation. So communication, cooperation, and overall emotional atmosphere. That's just the data there to support that. So what's contributing to that effect? We've seen that the kids seem to have some sort of behavioral difficulties after these injuries, but what is really contributing to it? So again, so this is published data if you want to go and see the details of the regression model, but we put in several factors. And what we found was on the parent side, higher education and or socioeconomic status was predictive of better quality interactions. That's a finding that's sort of overall with these sorts of measures. And also whether the parents reported greater couple satisfaction was also associated. On the child side, somewhat unsurprisingly, but as we might expect, if the child had fewer sleep and behavior problems, then the quality of the interactions were better. However, this is somewhat counterintuitive, but if the parent reported that the child had more post-concussive symptoms, they actually had better parent-child interactions. So I'll let you think about that for a minute. At first I said, no, to my student, you've gotten that wrong. The direction is wrong. They should, if they have more symptoms, they should have worse interactions, but it's not. This is the direction that it's in. Okay, why would more post-concussive symptoms be associated with better quality child interactions after early concussion? This is my explanation for it. I'll walk you through this with a concrete example. But a couple of years ago, we published these pathways for trying to understand when young kids have post-concussive symptoms, what might be going on to explain these sort of prolonged behavioral and parent-child effects. So I won't go through all of these pathways, but basically, if a child is showing post-concussive symptoms, there are three major factors, I think, that are going to contribute to what the outcome is and whether they recover well and whether they continue to show symptoms or not from a behavioral perspective. So one, the parents has to perceive that they have symptoms. As I said at the beginning, it's kind of hard, right, to know whether a child has symptoms because they might not be telling you. Two, they have to attribute it to the injury. You know, throwing a tantrum, what could that be? That could just be the terrible twos, right? So they could be throwing the tantrum because they feel horrible. They feel nauseous and headachy and they don't want to put their shoes on. But a lot of parents might just say, oh, what a difficult day. You know, I wish my child would put their shoes on. And then it's also about whether the parent is going to respond to that. Are they going to just insist for the child to put their shoes on because they need to get to daycare? Or are they going to maybe say, oh, maybe my child's not feeling well because they had a concussion. So maybe I need to be a little bit more lenient or a little bit more tolerant or flexible today. Okay, so I kind of already walked you through this example, but basically, you know, a 2-year-old, like the one we saw in the video, might have a headache. They might cry all the time because their head hurts, and the parent may not perceive that symptom because they're just like, oh, my child's crying all the time, how annoying. And then, so they won't change their behaviors and they'll just keep on with their daily. And that might lead to the child just not feeling well and asking for more and showing more difficult behavior. They might find that the child's very irritable and so they've perceived it, but they might just go, oh, that must be just the terrible twos then. They might, so in that case, they don't attribute it to the concussion, and they might, you know, attribute it to the concussion, but they might not change their behavior in terms of what they're expecting of the child. Okay, so hopefully that seems somewhat clear to you. This is just a summary of it saying really at this age, I think we need to be thinking about what the child's experiencing, but also how what role the parent has in the child's recovery and how they can help them. I'm not putting all of the onus on the parents. We as clinicians and health professionals and researchers need to obviously be paying attention to this, but they're the ones there every day trying to figure out what's going on with the child, okay? So I'm going to move to just a different section and then we'll kind of come back and wrap that all up at the end. I've said a lot about behavior and I haven't said very much about the actual brain. And actually, when I was first invited, I was asked to speak about neuroimaging data, but my disclaimer right now is I'm going to present to you some very preliminary work with very little actual quantitative data in it, but you can sort of watch this space as we work through the data. So behavior, but what about the brain? So lots and lots of studies. I've just put 3 up here as examples, but that, you know, advanced neuroimaging sequences, advanced MRI sequences, you know, could be possible biomarkers for prolonged symptoms, for example, or could be useful for diagnosis or for prognosis. So many people have looked into that, but not very many people have acquired data in young kids to see whether that might also be the case or whether that might be useful. And I guess in our lab, we just like really difficult things. So this is just an example, from an older child, from a study we did a few years ago during my postdoc, actually. This is just showing, you know, CT versus conventional MRI versus susceptibility weighted imaging. And you can find some additional things on susceptibility weighted imaging if you using advanced techniques. So this is just the preempt to what I'm going to say. Obviously, motion is a significant concern in terms of acquiring good MRI data. So in this, hopefully you can see, you know, on the left side, these are images that are quite good quality, but on the right, there's motion artifacts that you can see through the little lines through the brain there and some blurring and ringing artifacts. Okay, so what we did was we thought, well, We can't sedate these kids to put them in the MRI because this is just a research study and that's unethical and we don't want to do that. But we collaborated with Catherine LaBelle, who's at Alberta Children's Hospital, who has been quite successful in gathering MRI data from kids as young as 2 years old. So what we did was we developed our own, in Montreal, play and behavioral familiarization to decrease, well, not just decrease the need for sedation, that was sort of a more global clinical objective, but to actually acquire these images for research purposes. So in this first study, we compared the success and the quality of the images that we acquired using this. So what the kids did was they came in and it took about 10 to 15 minutes. We have a little book that says it's a little book with animals and it explains the MRI process and they can listen to the sounds, and we have puppets and we have a little play MRI that the kids can play with. And then they go in and they watch a movie throughout all the sequences, including the resting state, okay? So that's sort of the procedure there. For those of you who like this kind of detail, those are the imaging sequences. This is a published study, so you can go and see the exact sequences we used. And this first set of data is on just a small set of kids, 37 kids, 13 that had concussion and 24 who were typically developing. And they were between 3 and 5 years of age. So what we did was we set out a sort of a priori, success criterion, which was that we really wanted them to get to this QSM susceptibility sequence. If they did that, we considered that we'd gathered the most important data that we wanted. If they continued on through the rest, then that was like a bonus for us that we got all these other sequences. So you can see there the percentage of kids who went through and who reached the success criterion. So 77% of the concussion group and 63% in the child group. Now you might not think this is a huge success rate, but it really is when you're trying to get a 3-year-old to go into an MRI scanner and to stay in the scanner. So even at the end, we've got about 50% staying in for a period that's about 30 minutes, okay? There were no differences in the rate of kids, whether they were controls or concussions. So this is good for us. This is indicating that they're just as able to go in and for us to acquire data. Of course, success decreases as we go on in the sequences. They want to get out more, but none of the kids were distressed or really upset or really scared. They were mostly just bored. And so they started to fidget and they wanted to come out. Okay. One of my former postdoc, who has 10 years of extensive experiences, rated all the sequences for the quality of them. So basically the quality of the sequences that we've looked at so far, the T1 images, the diffuse intention images, they were really good quality, 100% great, excellent quality, or 93%. So basically the bottom line here is, if you can get them in, you're going to get really good data. So it's more about whether they actually go in or not, because some kids would say that they were going to go in, but would just not even lie down on the table. So once you get them in, you can actually get quite nice data. We were interested in what predicts the success of the MRI so that we can improve this and we can get even better data. And so the parents filled out just a really quick qualitative questionnaire that we asked the question a few child after. And we also had some of the research team answer a few questions. And what that data looks like is what predicted the chance of success. The parents' concern was a significant predictor. So actually, it didn't matter whether the child seemed nervous or anxious or happy to go in, but if the parent said, I'm not sure my child's going to be able to, oh, it seems really long, and they're really active, and I don't think, then that was a negative predictor of the child being able to do it, okay? Of course, the older children had better success than the younger children, and really interestingly, I thought, again, is when we asked just a simple question to the research assistant and the MRI tech, do you think this child is going to do it? Their answers were accurate in predicting the success. But if we asked the parent, do you think your child's going to do it? Then they were not accurate. Okay, so you can imagine why that is, right? They're worried. They're more worried than the child is about going in the MRI scanner. Okay. We also asked the kids, for example, did you like it? And most of them said, yeah, it was fine. They got to watch a movie, right? So, and 64% said they would do it again. Okay. So some of them said it was fine, but don't put me back in there. This is just the teaser slide. We've just started to look at the actual quantitative data, the volumetrics of it. So I'm not super confident in this data yet. It was only on a subset of the participants, but we now have 42 kids with concussion, 25 controls, and 11 orthopedic injuries. So we're going to keep plugging away at this data to see whether in the actual quantitative analysis, we find any differences. So I'm going to wrap up. Oh yes, I was going to say, getting good brain images after concussion is basically also about behavior and whether you take the time to explain to them and let them play and familiarize themselves. So I'm coming back to this slide. I showed this at the beginning. What are the unique characteristics of early concussion? And I really do think the unique characteristics require unique approaches. There's the famous, from Krisky, the saying, children are not little adults. Well, little children, yes, they are little children, but they also require adaptations to what we're doing so that we don't just keep saying, oh, these kids don't have concussion or these kids don't have symptom because we haven't actually measured them properly or we haven't adapted our expectations and we haven't adapted our management or our treatments to what these kids need. We're thinking about what are the pathways forward. In some ways, this subdomain of concussion research is easily maybe 10 years or more behind, I would say, what we know about pediatric concussions and adult concussions generally, in the sense that we don't have great definitions. People don't necessarily agree on them. We don't, doctors that I work with will often say to me, yeah, but you're showing this all to me, but what do I tell the parents and where do I send this child after I've told them that they have a concussion? I don't know what the clinical pathways are, and I don't have any intervention to propose to them. So there's a lot of work to be done. So this is my call for people to get interested in this area and to contribute to these pathways forward so that we can improve concussion knowledge for this group of the population as well. This is just the reactions measure that we're now sharing with people if they want to use it. We also have a reduced 8-item questionnaire that is really derived from the emergency department data that we have. So it's the 8 items that are the most sensitive in the emergency room in our sample. So it's sort of like an acute screener. And the other sort of more knowledge translation things that we're working on are we have now a community concussion detection tool. So this is sort of similar to what you might know as the concussion recognition tool, but adapted to young kids. We have this big program in Quebec for educating early childhood educators on concussions, and not just in daycares, but also integrating that training into their college training programs so that everybody gets it before they actually go and work in daycares. And of course, there's goals to extend this to other health professionals and to other community actors who work closely with these kids. So I think that's it for me. And I'll just thank a lot of the work that I've mentioned today has been from my students, PhD students who've worked really hard on this data. So a big shout out to them. Thank you.
And remember one of the on the virtual the 1,091 per 100,000, was that an incidence or prevalence?
Incidence,
Incidence,
yeah.
okay. Any other?
I feel like if we were to measure your resourcefulness, you would be in the 99th percentile.
Thank you, Robin.
That was an amazing presentation. And the strategies you used for trying to capture data and that allowed you to get great data were really so impressive. I just was wondering, actually, in terms of the materials, do you also have materials that provide clinical recommendations to parents?
So we're working on those. You know, I almost hate to put that slide up because then I get people asking me for them. And we're really like, we're trying to move forward so quickly so that we can disseminate this really quickly. And we want to do the recommendations too. I've been asked even from a hospital in Ohio if I can, you know, give them recommendations to put on their electronic portal and things like that. So we're working on those, as well as on helping people update a lot of hospitals have just like a pamphlet that they give parents about what to expect after a concussion. So we're working on updating those, helping people update those sorts of things so that they integrate examples of what to expect in a young child, for example. Forthcoming for recommendations, Robin. The reactions tool we're about to put on a website for people to just download. And if people want to use it for a research thing, then I can send that fairly easily to people. And the concussion, the sort of the detection tool, we've gone through a whole process of focus groups and expert committee validation, and that's ongoing so that we feel comfortable that we can, you know, we can share it with everybody and that there's a large consensus to what's included in that. And we're working with the pediatric concussion guidelines. I'm leading a subgroup so that we adapt the pediatric concussion guidelines so that there's a 0 to 5-year-old specific guideline.